So next up is Dr. Din Huynh Lin, who will be speaking about coronary artery disease and TAVI, challenges and strategies in the contemporary era.
Thank you, Mr. Chairman. Good morning, everyone. First of all, I would like to say thank you to Dr. Hui for organizing such a great sessions and for inviting me. So my talk today is there's something in relation to Prof. Hong's speech about coronary artery disease, because if we manage it well in the first term, we will have less trouble in the future in case of TAP in TAF. Okay, so it is a prevalence of coronary heart disease in some TAVI trials and registry, and you can see that the prevalence ranges from 20 to 80%. So it is not very uncommon to see a patient undergoing TAVI who has some kind of severity of coronary artery disease. And what we have learned from the guidelines is that Saver and cabbage is still the treatment of choice in case you have complex coronary heart disease, because it is superior compared to PCI plus TAVI in terms of short-term and long-term outcomes and complication rate. And the latest guideline from ESC about valvular heart disease just recommend of the 2A, grade 2A for PCI should be performed in patient who has more than 90% stenosis of coronary artery disease in the large vessel more than 2.5 millimeter. Okay, so what about the when is should we treat a lesion in patient undergoing TAVI or not? So it is result from the 5 TAVI presented and at EuroPCR, and you can see that what we have learned from this trial is that FFR guided PCI will result in lower rate of MACE compared to angio guided. But I think the result here is very modest. First of all, the number of cases is not so many, and the second is that we don't know yet about the reliability of FFR in case of aortic stenosis. It is suggestions. I don't think that we should perform FFR in every cases with some moderate lesion in the coronary. But this trial has some meaning, and if you look at the Notion 3 trial about PCI in TAVI patient, you can see that there are most of the cases has a very severe coronary artery disease, more than 90% of stenosis, or FFR less than 0.8. So the second question after we decide to do PCI or not to do PCI is the optimal timing of PCI. And we all know that PCI before TAVI, during TAVI or after TAVI all have pros and cons, and as an interventionist we should individualize in each case to decide in this case should it do before, or in this case you can defer after TAVI. So if we perform PCI before TAVI, what we have learned from the beautiful trial from Patterson, the activation, you all know about that, is that a patient, if you do PCI before TAVI, you will increase the risk of bleeding because you have to give DAPT for the patient, and then we perform TAVI, and we know that now the current guidelines just suggest SAPT after TAVI. So if you do PCI before, the risk of bleeding is higher. But if you leave a lesion untreated, what happens? We know that the prevalence of acute MI after TAVI will be just about 50% to 20%, and the prevalence of unplanned PCI after TAVI is quite infrequent. It is very nice report on the JCC circulation, and you can see that so if you leave a lesion untreated, even it is more than 50% stenosis of coronary artery disease, so in the next 5 years, the prevalence of PCI is just less than 20%. And it is a presentation published in TCT last month, and you can see that the critical success of PCI after TAVI is pretty good, up to 93%, and you can see that it is the very first generation of TAVI one, the core one, Sapien, long time ago, and you have no idea about commissural alignment, you have no idea about implantation depth, long time ago. So I believe that with the latest generation of THV and with more technical consideration, we have a higher rate of successful doing PCI after TAVI. So what is the technical considerations of that? It is shown in the aligned assess study showing that the type of TAVI1 or short frame, as Professor Hung said, will have a higher rate of selective angiogram. But if you have to implant a tall frame one like the Evolute, we should pay attention to commissural alignment. We should pay attention to the height as well as the width of sinus of one sava and also the depth of implantation if we want to protect coronary. Not at that time, but in the future, we should implant the TAVI one a little bit lower. So here is our one of our TAVI case we did last year, and you see that very tight stenosis in mid LED and proximal LED result in TME2 flow. So we decided to do PCI before TAVI because the flow is not so good, and we end up with three stent extending from left main to mid LED. The flow is quite good. So we because the patient is quite, I think, not very old, just 70 plus. So I think the next 10 years he may need another valve. So we choose short frame, the Sapien 3, and you can see that very good hemodynamic outcomes. And you can appreciate from this movie that we try to aim the valve a little bit lower, even for short frame Sapien, because I don't want to touch the coronary at all because in case of instant restenosis. So another case presented by my colleagues, you can see a case with severe stenosis proximal and mid RCI, but the flow is quite good. So they decided to put a TAVI one first, and the Sapien 3 26 was implanted, and you can see nicely that the coronary artery is still preserved, and 4 weeks later after TAVI they implant 2DS with good result. Yeah. So there's another case that I think is nice to show you that we did this case about 2 months ago. Patient is quite young, 70, but previous stent, multiple stent, left main, circumflex, RCA, pacemaker, and you can see that the RCA originates quite high from the ascending aorta, and patient is quite small, small annuli actually, so we decided to use Evolute for better hemodynamic in case the patient is not very old. So what I think is very important is that we preserve the commissural alignment. We use the Evolute R, not the latest generation Evolute FX, but I think that by using the head marker, you can see that it is very important to give the head marker at the central line in the curved overlap view, and after that we can perform a selective angiogram very good. The reason why you have to perform a selective angiogram because that the patient has tamponade after the procedure. Unfortunately, you can see the picture is here, and we have no idea where the effusion comes from. So we put him on the cath lab and we perform coronary angiogram, and it's quite not very hard, but quite easily to perform it. So I think commissural alignment is very important. You can see the picture is here. We do the synthesis. Okay, so now we only use the Evolute FX with a 3 gold marker, and you see that with the 3 gold markers and with the curved overlap view, we have the 2-1 pattern here. And if you respect that, in almost all the cases, you can have a very nice commissural alignment. It is our case we did last month, and you can see the 3-1 pattern here. And after that, we perform a post-TAVI multi-slice CT, and you can see the valve here. Due to severe calcification, the valve is not fully expanded, but what I have to show you is the left main here, and the RCA is coming from here. And you take a closer look, you can see the three neo leaflet here, and it is, I think, very good commissural alignment. Okay, you can see it. Um, and it is beautifully shown in the latest trial in the aero intervention last month, the cannulate TAVI expanded study by Dr. Ono, showing that if you respect commissural alignment using FX, you have 100% of successful to do selective angiogram with the left, and 97% with the right, quite good. So in conclusion, I would like to say that coronary artery disease is quite common in patients undergoing TAVI. So the indication for now is that we do coronary revascularizations for patients with more than 90% of stenosis or FR less than zero point 0.8. The optimal timing is not very, based on case by case basis, but post TAVI PCI, that is infrequent. So the technical considerations, we may use short frame, a VAR, like the Sapien or MyVAR, or if you have to use the Evolute, we should respect commissural alignment. And I do believe that PCI can be performed safely in patients with previous TAVI. Thank you very much.
Thank you, Dr. Đinh Quỳnh Linh.